Hello everyone. Now today we will continue our nephron physiology, and in nephron physiology we have discussed about glomerular filtration rate, proximal convoluted tubule, then loop of Henle, ascending loop of Henle, distal convoluted tubule. Now we will be discussing about the collecting tubules. Since we have discussed as what are the normal physiology, then what are the drugs that can be applied pharmacology, and what are the pathology, so we'll discuss in this lecture also the same manner. Okay, so suppose now we are discussing the nephron physiology of the collecting tubules. So this is your lumen where the urine is passing. This is the cell. This is the cell. Lumen urine is passing. This is the cell which is present over here, and the side is interstitial space. Is interstitial space and blood vessels. Okay, so the urine is passing in the lumen. When urine is passing in the lumen, normally if you have not used any diuretic also, then in the presence of ADH, if there is presence of ADH, I have told you then above the ascending thick ascending limb of loop of Henle or are impermeable to water. So if there is no ADH present, then water will not be absorbed. But if there is ADH secretion due to lot of factors are there for the secretion of ADH, we will talk about it, but like angiotensin 2 is responsible, then your blood volume osmolarity is responsible, they secreted from the posterior pituitary. Okay, if the ADH is secreted, what it do, it's create a pore, that is water channel, aquaporine water channel is created into the collecting tubules, and from which the water will get absorbed and maintain the osmolarity. Okay. So water absorption occurs only in the presence of ADH. Now when urine is passing and it contains the sodium, so your sodium contained here 3 to 5% of the sodium will be absorbed. Okay, so sodium will be absorbed through this sodium and potassium channel. Now they are not the single channel, they are two different potassium channels are there. This is the epithelial sodium channel known as the ENaC, and this is also the apical. This is apical luminal membrane, and this is the basolateral membrane. Now see, as previous, in the basolateral membrane there is sodium potassium ATPase form. Okay, and when this sodium is thrown out from the cell into the interstitial blood and potassium comes out, there is a lack of sodium. Due to the lack of sodium, this sodium gets absorbed into the cell and finally into the interstitial. This is occurs. Since sodium gets absorbed, now let me explain one more thing about that is aldosterone. This aldosterone is very important. In the presence of aldosterone, what it do, the aldosterone increase the activity of this sodium potassium ATPase form. So what happens, your sodium is more thrown out and potassium more coming. Since sodium more is lacking here, this aldosterone will increase the activity of this. It also increase the activity of this sodium epithelial channel ENaC. It also increase the permeability of these potassium apical channels. Okay, so what are the function? And another function is it increase the activity of this hydrogen secretion into the lumen, into the urine by this ATPase form into the alpha intercalated cell. So aldosterone has many functions. In the presence of aldosterone, there will be increased activity of the sodium potassium ATPase form. There will be increased activity of the hydrogen excretion in the alpha intercalated cell. There will be increased activity of this is principal cell, the sodium potassium ATPase form. Then there will be increased activity of the sodium epithelial channel, which is known as the ENaC. There will be increased apical conductance of the potassium in the presence of this aldosterone. So now when urine is passing, sodium is getting absorbed. In the presence of aldosterone, the activity of sodium ATPase activity has increased. So there is relative lack of sodium. So due to relative lack of sodium and increased conductance of this channel, sodium comes into the cell. When sodium comes into the cell, then what happens? There is a positive charge has come into the cell. So there will be the luminal negativity. When luminal negativity occurs, what then happens? To neutralize this luminal negativity, this cell secretes out the potassium. So this sodium and potassium both is handling by your aldosterone, that you have to understand this both channel. Now since sodium has come out and luminal negativity has occurred, potassium will come into the lumen. This is urine lumen. Now this has the work of this principal cell has finished. Now when the urine is moving, here is now potassium. When it comes to the alpha intercalated cell, what aldosterone is doing? Aldosterone is secreting the hydrogen. So to neutralize the luminal negativity, aldosterone is secreting potassium from the principal cell as well as hydrogen secretion. This is ATP dependent from the alpha intercalated cell. So potassium is there, hydrogen is there. Now since when potassium is losing in the urine, this cell has another property. When it sees that potassium is losing from the urine, it will try to get that potassium into the cell. Okay, so to get that potassium into the cell, there is another bond known as sodium hydrogen exchanger, ATPase dependent bond, where this sodium will be absorbed and hydrogen will be excreted. Okay, but there are very small amounts. Because of that, the potassium is lost, although it is trying to get the possible potassium into the body. Okay, so this is the normal physiology. So what is happening if you are using any diuretics or anything you are using? Suppose you have used the diuretics. Suppose you have used furosemide, you have used thiazide diuretics. Now sodium is getting lost. More sodium. This furosemide working on the ascending limb of loop of Henle, and then thiazide working on the distal condylar tubule. This is occurring in the sodium potassium 2 chloride form. This is occurring in the sodium chloride co-transporter. So sodium and chloride is going to lost in the urine. Since what this tells us, the body is saying that sodium is lost. In the presence of aldosterone, more sodium is absorbed. In the presence more sodium is absorbed, the more potassium is excreted. Since more potassium is excreted, they are trying to bring the potassium into the cell, but potassium is still excreted and you are creating hypokalemia. Because of this normal physiology, since you are losing your potassium into the urine and developing hypokalemia, so to combat that, normally this potassium sparing diuretics are there, which will act on this place and prevent the loss of potassium. I will explain how. So there will be always combination of thiazide with potassium sparing diuretics, because I have told you already there is only 3 to 5% of sodium absorption from this. This is a very weak diuretic, and since it needs to be most of the time needs to be used in combination of furosemide or thiazide diuretics. Okay, now let me come here the pharmacology. Since you have understood the physiology, now if we are going to, there are two potassium sparing diuretics is two types. One is aldosterone receptor antagonist and another is sodium channel blocker. Now see, when you are using this aldosterone receptor antagonist, you are blocking this aldosterone. Since this aldosterone is blocked, your receptor is blocked. Your receptor is blocked. Now there is no activity of this increased ATP, so sodium potassium ATP is blocked. So no lack of sodium here. Since no lack of sodium, there is no need of absorption of sodium. If there is no need of absorption of sodium, there is no luminal negativity. If there is no luminal negativity, it doesn't need to secrete the potassium, doesn't need to secrete the hydrogen. So your hydrogen and potassium is not secreted out here of your body, and because of that your potassium is preserved, and because of this it is known as the potassium sparing diuretics. Means that your potassium is spared, your potassium is kept inside your body itself. Have you understood this point? So this is the pharmacology, how it's work. So if you are going to use spironolactone or alpirinol, these are the aldosterone receptor antagonists, and this will block this for this 1, 2, 3, 4. Normally 3, so it doesn't require to secrete the potassium, and because of this, now you are not losing your potassium from your body. But this is spironolactone, aldosterone receptor antagonist, has one major side effect known as the gynecomastia. Gynecomastia can occur due to lot of reasons, but the important point of this spironolactone is it is going to have painful gynecomastia. So you have to differentiate gynecomastia from other cause, and from spironolactone is it will be a painful gynecomastia. Okay, now there will be other, since steroid hormones, then there will be other anti-androgenic effect as well. Okay, so you have understood this. So to combat this, we can use another mechanism, we can use another place to preserve our potassium, and that will be the blocking this sodium channel. Suppose you have blocked this sodium channel. Now if sodium channel is blocked, whatever the aldosterone mechanism is, how much aldosterone is in your body, maybe it increases many times, but if sodium channel is blocked, okay, so this will acting here in the receptor, and the receptor increasing the activity of this and increasing this secretion. But since this is blocked, you have blocked over here, and there is no any place of sodium absorption in the collecting tubules beside this channel, this inact, that is the epithelial sodium channel. Now sodium is not absorbed. Since sodium is not absorbed from your urine, there is no luminal, no urine negativity, no luminal negativity. Since there is no luminal negativity, there is no necessary of secretion of this potassium, secretion of this hydrogen into the urine. Since there is no necessary of your potassium secretion, now your potassium is preserved. Now your potassium is not going to lose. You are not going to have hypokalemia, and by blocking this only, also you can preserve your potassium. This is also a potassium sparing diuretics, and they are sodium channel blocker. This ENaC, that is epithelial sodium channel blocker, and name is triamterene and amiloride. This can be used as a potassium sparing diuretics. So you have understood about this two kind of potassium sparing diuretics. Now we have understood the physiology, we have understood the pharmacology. Now let's understood about the two pathological condition. There is two pathological condition. One is known as the Distal syndrome, and one is syndrome of apparent mineralocorticoid excess. Let me explain about the Distal syndrome. I have explained you when we are talking about the PCT, there is the absorptive defect in the PCT, that is known as the Fanconi syndrome. When there will be the absorptive defect of the ascending thick limb of Lemley, ascending limb of loop of Henle, that is thick one, then that is the Bartter syndrome. When you come to the distal convoluted tubule, when there is absorptive defect, then that is known as the Little-Man syndrome. So these all are the absorptive defect. There is lack of absorption of that from the renal tubules, and the syndrome, respective syndrome is there. But here, if you talk about this Little syndrome is mutation in sodium channel. Since sodium channel is there mutated, more sodium is absorbed. More and more sodium is absorbed. Since more sodium is absorbed, what happens? More luminal negativity will occur. More luminal negativity, potassium will be excreted, hydrogen will be excreted. Okay, so there will be again, if potassium is excreted, then there will be hypokalemia. So first you remember more sodium has been absorbed. Since more sodium has been absorbed, now what happens? Since sodium is more absorbed over here, then patient will develop hypertension. With sodium, water comes, and there will be development of hypertension. Then there will be another condition. If this sodium is coming into this cell, then there is luminal negativity. To combat the luminal negativity, potassium will be excreted out, so there will be hypokalemia. So there will be hypertension due to sodium. Excretion of the potassium will lead to the hypokalemia, and due to combat this, when potassium is going to lose, there will be a potassium hydrogen exchanger. Body will try to try to absorb the potassium, and for which it has to secrete the hydrogen. Even here hydrogen will be secreted, so there will be hydrogen ion into their lumen. Okay, to combat your negativity also, because sodium has been more absorbed, so hydrogen need to be secreted, potassium need to be secreted, both has come out. Now there is hypokalemia in your body, more potassium in urine, but in your body hypokalemia, and due to loss of this hydrogen ion into the urine, less hydrogen ion into your body, and metabolic alkalosis. So hypertension, hypokalemia, and metabolic alkalosis. This will be same as if you increase the aldosterone. If you increase the aldosterone, it will increase the activity of the sodium potassium ATPase. That will increase the activity of this channel, sodium channel. Then there is more sodium will be absorbed. More aldosterone, more sodium will be absorbed. If more sodium will be absorbed, more potassium will be lost, more hydrogen will be lost. And since there will be again, if it is a hyperaldosteronism, which is known as the Conn syndrome, then that also more sodium absorption, hypertension, more potassium loss, hypokalemia, more hydrogen is lost in the urine. So urine is acidic, but your body is metabolic alkalosis. So hyperaldosteronism, which is known as the Conn syndrome, and your Little syndrome, both are same presentation. How you differentiate? By the level of the aldosterone. In this aldosterone Conn syndrome, hyperaldosteronism, aldosterone will be increased, but in Distal syndrome, aldosterone will be in normal level. Yeah, I hope you have understood this. There is another disease, another pathology known as the syndrome of apparent mineralocorticoid excess. What does it mean? It means that there is one cortisol is converted into cortisone. This is cortisol. Cortisol has activity against this receptor, mineralocorticoid receptor, but it is get inactivated by 11 beta hydroxysteroid dehydrogenase. Okay, 11 beta hydroxysteroid dehydrogenase. These are the enzymes that convert your cortisol into the cortisone. Since cortisol, due to any cause, like due to hereditary deficiency of your 11 beta hydroxysteroid dehydrogenase, or one will be hereditary, another will be due to acquired, and acquired can be due to there is a leukorise. Use of this leukorise may cause us this 11 beta hydroxy dehydrogenase deficiency. What happens if cortisol is not converted into the inactivated form? This cortisol will act on this mineralocorticoid receptor and act as a aldosterone. So it is same, means it is just a formula to remember. Same means same as aldosterone. Syndrome of apparent mineralocorticoid excess. It means that cortisol is excess, which is usually converted into the inactivated form due by this enzyme. But if this enzyme is deficient due to hereditary or due to acquired condition, then this cortisol will act on this receptor, mineralocorticoid receptor, and act as a aldosterone. Since it is in the body, increase in the body, act as the aldosterone, increase activity of this receptor, increase activity of sodium potassium ATS forms, increase activity of hydrogen, there will be increased sodium absorption, hypertension will develop, increased potassium excretion, hypokalemia will develop, increased hydrogen ion excretion, metabolic alkalosis will develop. So hyperaldosteronism, Distal syndrome, and same, that syndrome of apparent mineralocorticoid excess. All these three will have similar presentation. Only difference is Cone syndrome and hyperaldosteronism, there will be increased aldosterone, which can be differentiated from these two places. Okay, now these two syndrome. Now if these two has same, in both conditions aldosterone will be low, but these two can be differentiated by measuring this 11 beta hydroxy dehydrogenase enzyme. If it is deficient, then it is due to syndrome of apparent mineralocorticoid excess, or even we can measure the cortisol level, or if this enzyme is not deficient, then it is due to Distal syndrome. Okay, so you have understood the physiology, you have understood the pharmacology, you have understood the pathology. So in this way we can integrate. There is another thing we can also talk about here is, okay, let me discuss about if you are talking about renal tubular acidosis, this is distal tubular acidosis type 1, proximal tubular acidosis, this is type 2, and there is hypokalemic tubular acidosis. Okay, hypokalemic renal acidosis. So we'll talk about distal condition. Since we are talking about the distal tubular acidosis, in distal tubular acidosis, what will happen that when distal tubular acidosis, this hydrogen secretion will be impaired hydrogen secretion. This is the deficient in your distal tubular acidosis. Since this is impaired, now what happened? Your hydrogen is not secreted out. But then since your hydrogen is not secreted out, it is present inside your body, then there will be development of acidosis. Okay, one major thing will be the pH should be greater than 5.5. Since hydrogen is not coming into the urine, so urine pH will be 5 point greater, means this hydrogen ion makes the urine pH less acidic, but since it is not secreted out, urine pH will be more. That you have to understand. Another thing is that since hydrogen is not excreting in here, then always in place of hydrogen excretion, there will be absorption of this bicarbonate. Now if the hydrogen is not excreted, the bicarbonate will not be absorbed. and since bicarbonate will not be absorbed, there will be development of acidosis. Even hydrogen remains inside the body, it will contribute for acidosis. So there will be urine pH more than 5.5, acidosis, metabolic acidosis will be there, and there will also, due to the loss of this, if hydrogen ion is not going on, then potassium will be lost and hypokalemia of the. So what are the features of your distal tubular acidosis, which is known as the type 1, and there will be pH greater than 5.5, acidosis, metabolic acidosis and hypokalemia. These are the features of your distal tubular acidosis, which is known as the type 1. Okay, and the causes we'll discuss later, but their usual causes are amphotericin B and toxicity, then there will be an analgesic nephropathy, then congenital anomalies. If there is obstruction downward, then we will also cause this distal tubular acidosis type 1. Okay, now let me talk about the type 2. Type 2 is nothing. Type 2 is about proximal convoluted tubule. Proximal convoluted tubule. In proximal convoluted tubule, this is proximal convoluted tubule. Proximal convoluted tubule. This is proximal renal tubule acidosis. This is type 2. What happened here? Due to any reason, bicarbonate we have talked about. If you are talking about proximal convoluted tubule, the proximal convoluted tubule, bicarbonate ion is absorbed, major portion. If bicarbonate is not absorbed, then what happened? Due to Fanconi syndrome or due to carbonic anhydrase inhibitor acetazolamide, then this bicarbonate will be lost from your body. Since bicarbonate will be lost, then there will be acidosis, metabolic acidosis. Okay, but distal tubule, hydrogen ion secretion is not impaired. Since it is not impaired, urine pH will be less than 5.5. That we have understood. Here, no damage in the, because it is in the proximal convoluted reabsorption of bicarbonate. So their urine pH will be less than 5.5. Metabolic acidosis will come component, and hypokalemia will be there. Hypokalemia is due to, since there is loss of, if Fanconi syndrome, there is loss of everything, so sodium is going to lose. If more sodium is lost, potassium is excreted out. Since potassium is lost in the urine, there will be hypokalemia. So both in distal, that is type 1 acidosis, there will be hypokalemia. In type 2, that is proximal tubular renal tubule acidosis, also will be hypokalemia. That we have to remember. Okay. Now there is another condition known as the hyperkalemia. Okay, this is type 4. Type 4. This is known as the hyperkalemic renal tubular acidosis. Hyperkalemic renal tubular acidosis. The name indicates that there is hyperkalemia. What happened? Due to any reason, if your aldosterone has decreased, hypoaldosteronemia. If due to hypoaldosterone is decreased, then this receptor and this receptor is not working. There is no activity, increased activity of sodium potassium ATPase. No activity, no sodium is absorbed. Since no sodium is absorbed, there is no necessity of potassium to be excreted out. Now potassium remains inside your body and it increases. This is not, due to this there will be hyperkalemia. Okay. Also the hydrogen is excreted, so pH will be less than 5.5. There will be hyperkalemia and pH will be less than 5.5. That is this two important. There is also other mechanism there, but differentiation is hyperkalemia. Why does hyperkalemia occur? Because this is due to decreased aldosterone or any reason due to lack of activity of aldosterone receptor. That we'll discuss later about the causes. So hope you have understood type 1, type 2 and type 4. Differentiation is type 1 is distal type, type 2 is proximal type. Type 1 there is pH is greater than 5.5, type 2 pH is less than 5.5, where here also pH is less than 5.5, but in these two there is hypokalemia. So potassium is less over there. Both potassium is less, but how can you differentiate? By urine pH. Urine pH is more in type 1 and less in type 2. Here the hypokalemia is there, but urine pH both are less than 0.5. But how can we differentiate? There is hypokalemia, this is hyperkalemia. In this way we can differentiate the renal tubular acidosis. Okay.